Welcome to this talk on endovascular therapy for acute stroke patients. This talk is designed for emergency physicians who work in departments that do not have a stroke neurologist, an interventional stroke program, or a comprehensive stroke team. My name's Blair. I'm an emergency medicine specialist who works at the Durham Region District Stroke Center, and this talk is on behalf of the Central East Stroke Network. I'll go through 12 slides in 12 minutes that talk about large vessel occlusion that may be amenable to EVT. First, we're going to review some terminology, neuroanatomy, and literature. Then we'll get into the indications for TPA, EVT, and we'll talk about common CVA mimics. We'll move into right MCA syndromes, left MCA syndromes, and PCA and basilar syndromes. And then we'll talk about scoring methods, operationalizing all of this, and then the bottom line. Just to quickly review terminology, acute ischemic stroke is caused by thrombotic or embolic material that partially or completely blocks blood flow to part of the brain. Neurons are extremely sensitive to hypoxia. We know that about 2 million neurons die for every minute for which a stroke is preventing blood flow to part of the brain. Like in STEMI, vessel reperfusion has traditionally been achieved using intravenous thrombolytics. TPA has been the traditional drug of choice, although TNK is quickly becoming favored for its ease of administration and demonstrated non-inferiority. However, thrombolysis is only marginally effective for large vessel occlusions and carries cerebral and systemic risk of bleeding. Large vessel occlusion refers to a clot in a proximal, wide caliber blood vessel in the brain. These include the internal carotids, the middle cerebrals, and sometimes the anterior and posterior cerebral arteries and the basilar artery. Like in STEMI, recent advancements allow specialized physicians to access these blocked arteries by endovascular means. Clots can be mechanically removed, like in thrombectomy, flow-limiting lesions can be stented open, and local TPA can be administered. Because of technical limitations, EVT can only be applied to large vessels, but fortunately for ER physicians, many large vessels will present syndromically. Blood supply to the brain is divided into the posterior and anterior circulation. Let's start with posterior circulation. Your vertebral arteries join to form the basilar artery, which comes up into the right and left PCA. The vertebrals supply the posterior inferior cerebral artery, a blockage here causes Wallenberg syndrome, and the basilar artery supplies the anterior inferior cerebral artery, the pontine arteries, and the superior cerebellar artery. Blockages to the brainstem can cause dysfunction such as coma or cranial nerve deficits such as ocular motor deficits. The posterior cerebral arteries supply the occipital lobe, inferior temporal lobe, the midbrain, and most of the thalamus. Visual field deficits are the most common way that these strokes present, although because the thalamus can be taken out, many different stroke presentations are possible. Thalamic strokes are super tricky. Often these are tough even for stroke neurologists to determine clinically. The posterior circulation in most people is connected to the anterior circulation through the posterior communicating artery, and the internal carotid arteries are what feeds your main anterior circulation by passing through the petroskull up into the cranial vault. They become the middle cerebral artery at the same place where the bifurcation to the anterior cerebral artery occurs. The MCA feeds the deep gray matters through small arteries and then comes off the M1 segment to bifurcate into the superior and inferior MCA. The ACA feeds the frontal lobes and then moves anterior and then posteriorly kind of up and around the back of the head. MCA strokes make up about 2/3 of all large vessel occlusions, whereas ACA strokes make up only about 2 or 3%, and that's because of the angle, the steep angle the ACA comes off the ICA-MCA bifurcation. The rest of strokes, about 1/3, are posterior. PCA strokes are tough to identify. They require a high index of suspicion, and often they can present very subtly. We'll talk more about this in a moment. This talk is not meant to convince you that large vessel occlusions require EVT therapy. I think we're all on the same page with that. Multiple studies have shown that in the right patient, EVT has very successful outcomes. The number needed to treat for patients less than 24 hours of symptoms is as low as 2. And the absence of CT perfusion scanning, while not optimal, does not exclude transferring a potential EVT patient to an interventional stroke center. For example, the Mr. Clean trial, which sort of launched a lot of this to make EVT standard of care, did not use CT perfusion scanning. We've all heard about the arguments for and against TPA. This talk is not about the NINS trial or the ECAS trial and all the other information and data that we have to inform TPA practice. We know that TPA bleed risk increases with time, and that certain centers use a 3-hour cutoff from last seen normal, others use 4.5. Regardless, most emergency departments have protocols to help patients access TPA, and those systems almost always refer eligible candidates to EVT when appropriate. We're going to focus on patients who are not TPA eligible. Keep in mind that in some places without comprehensive stroke programs, a TPA doctor may find a contraindication to TPA and hand the case over to the emergency physician without ordering imaging, in which case we should still pursue emergent LVO investigation. This person might still have a large M1 occlusion that would be treatable in a timely manner with EVT, and so just because they're not eligible for TPA, even if they're, say, 60 minutes after presentation, does not mean that that patient should not be emergently worked up for their acute stroke. The ultimate challenge in acute stroke management, of course, is weighing the benefit and con of reperfusion and the bleeding risk that comes with either lytics or reperfusion alone. Traditionally, we've used last seen normal time to help us determine that risk-benefit ratio. But last seen normal time is fast becoming obsolete in stroke care. The idea behind last seen normal is that after a certain time period, infarcted tissue cannot be recovered and ischemic tissue is at high risk for bleed conversion. But each brain is different. We know that collateral blood flow may mean that some brains have more time while others have less. That's where CT perfusion technology comes in. It allows us to individualize the risk-benefit for every patient in front of us. What you see here is in green is the penumbra, or the ischemic area that can be saved, and it's compared to the pink core or umbra, the infarcted area or the predicted infarcted area that is not recoverable. When you take the green and the pink and compare the two sizes, you can determine if this patient would be eligible for LVO therapy. Some places use an absolute value, such as 15 milliliters, whereas other places use a ratio of 1.4 or 1.8. Either way, if you have a large mismatch, meaning a lot of green and not a lot of pink, this patient is eligible for LVO therapy. In places that don't have CT perfusion scanning, we use the aspect score. An aspect score greater than 7 is quite favorable, 10 would be perfect, and usually a cutoff for determining LVO therapy would be, EVT therapy would be somewhere around 6 or 7, but it is kind of case dependent. Ultimately, patients require CT perfusion to best understand their risk of bleeding should you go ahead and reperfuse with thrombectomy. So this technology is rapidly evolving here at Stanford. It's really quite interesting to see the decision-making that goes into whether or not we're going to reperfuse a patient's brain. What you can see here is that that green area of penumbra, that at-risk territory, can be further divided up to be either super high risk or less high risk for bleeding and for benefit of reperfusion. So here you see a large red core. This is very bad green. It's on the brink of becoming pink. And so this patient would unlikely to benefit from LVO therapy. Whereas the hypoperfusion on the opposite side is quite favorable for delayed hypoperfusion. And although the studies looked at, well, as we know, we've gone from 3 hours to 4.5 to 6 hours to 8 hours to 16 hours to 24 hours, and we do know that there are patients over 24 hours who have sufficient collateral circulation that they can still benefit from EVT. So even the 24-hour rule is not absolute. Well, traditional EVT has looked at NIH cut scores of approximately 6. I prefer a more nuanced approach, and instead of using an NIH cut score, I would ask yourself, is this patient going to appreciate the benefit of treatment? So if you're a world-class piano player with a weak hand, or an emergency doctor who's aphasic, you may have an NIH score that is below 6, but for you, reperfusion might be really, really important. Whereas for other people, like a demented nursing home patient with an NIH score of 20, they may not be able to appreciate the benefit of reperfusion if their baseline was quite poor. Looking at the top line here, generally we use a cut score of 24 hours from last seen normal. We're looking for some sort of unilateral arm weakness, sometimes facial droop, since your arm and your face are side by side on your motor homunculus, and then a symptom that would indicate large vessel occlusion. So those large vessel occlusion syndromes are visual defects indicating a PCA lesion, aphasia indicating an MCA lesion on the left, and neglect indicating a right MCA lesion. When we're assessing for this, it's really important that you not ask your patient to mimic. So instead of saying, show me 2 fingers, you should ask them, show me 2 fingers with your hands behind your back. If you do this, then they might do this as well, and that could just be mimicking. They might not actually have language capability, and so you could underscore your NIH that way. So be sure that you have them perform tasks without mimicking. For assessing neglect, I'd like to stand on their left side and tap and call their name and see if they'll turn and look at me. And for aphasia, I'll run them through a number of things like, what is this? I'll show them my pen and see if they can tell me what's going on. The bottom line is that if you have a patient who you think is in an acute window, who might appreciate the benefits of reversing those deficits that they're presenting with, you should consider consulting EVT. A couple common stroke mimics that can throw us off. First of all, we can have seizure, syncope, sepsis, vertigo, Bell's palsy, hypoglycemia, and certain toxicologic presentations. These do not need a head CT. Certain other things might not go for EVT, but would still be an emergent finding and may require neurosurgical consultation or other emergent care, such as an intracranial bleeding, brain malignancy, brain abscess, and traumatic brain injury. Right MCA syndromes present generally with arm weakness greater than leg weakness, and can also be caused by ICA occlusion or tandem clots, and affect the basal ganglia, parietal, temporal, and frontal lobes. Neglect is a little bit tricky to discern. It can be visual neglect or tactile neglect, but it should always be top of your mind when you're assessing patient on the ambulance stretcher. Left MCA syndromes, the key here is looking for aphasia. So in the top arrow, you see Brokaw's area, which affects speech expression. They may not be very fluent, so they may be stuttering or really trying to get the words out, but they can't. In Wernicke's aphasia, indicated by that bottom arrow, they may be fluent, but be speaking gibberish or a word salad. And so in these patients here, their speech is easy, but their words are not making a lot of sense. You can also have people who have global aphasia, which is that they can't really make sound at all. And you always want to be able to parse this out. Is this a problem with language in the brain, or is this a problem with speech, which could be about dysarthria, problems with the tongue, problems with the lips? That would be a different part of your NIH score. Posterior syndromes, super tricky. About 30% of strokes, though, are posterior, so it's very important that you think about these. To ignore posterior strokes would be like only looking for left coronary artery infarcts and STEMI and ignoring all the right-sided infarcts. So it is really important to pay attention for posterior syndromes in the occipital, thalamic, and cerebellar regions. And also to always remember your basilar syndrome, which is super tricky because these people do not present with focal deficits. They can have paralysis in all extremities, somnolence or coma, and present without focality. These patients still need stat-CT-CTAs because finding a basilar artery occlusion is essential to that patient's outcome. These are sometimes a tricky sell to radiologists because there is no focality, but certainly the stroke neurologists would advocate that people for concern of basilar syndrome should have stat vessel imaging. We've all heard of the NIH stroke score, and many people use bedside tools to help them remember how to calculate it. The NIH score was never really meant to diagnose stroke. It's more designed to communicate stroke severity. It has its flaws. It's heavily weighted towards language. So a left MCA stroke with a 25 milliliter volume could have a NIH score of 20, while a stroke on the right MCA of an equivalent size might only have a score of 12. It's also weighted for anterior circulation and less so for posterior circulation. The ACT-FAST score is very common right now, both in pre-hospital and emergency department settings, to screen for people who might be amenable to LVO therapy. Act Fast is really good at identifying MCA strokes, not so good at identifying posterior strokes. So it only picks up about 2/3 of things amenable to EVT. Now, if you're having a posterior stroke, you'll probably present with visual symptoms. That's why some emergency doctors use the VAN score, which in addition to screening for aphasia and neglect, like Act Fast, also looks for visual disturbances. This can improve your sensitivity and help you catch difficult to find LVOs that might be amenable to EVT. Now, the bottom line is that if you have acute focal neurological deficits that, if reversed, you think your patient would appreciate recovery from, that person deserves a stat CT head with a CTA to rule out large vessel occlusion. And if you don't have anything focal, you still need to think about basilar artery stroke and consider emergent CTA in those patients as well. That was a lot of information in a very short period of time. Let's talk about real life. Here's what a potential workflow could look like in your emergency department. There are 3 things that you have to do: screen the patient, scan the patient, and send the patient. So here's a simplified algorithm. Part 1, screen. If it's greater than 4.5 hours and less than 24 hours, this patient might be eligible for LVO. Screen them for symptoms, and if you think that they have an LVO syndrome, screen them for eligibility criteria. If everything looks good to go, move on to part 2, scan. Call a code EVT and make sure that at your institution any required paperwork is filled out. This could include CT and CTA requisitions, or in some places a consent form for contrast, often under emergency consent. Make sure the radiologist will know how to get in touch with you, either through a pager, a cell phone, or through your receptionist. The next thing you'll want to do is make sure you head back to work and continue seeing patients while the scans are done. Once the radiologist has seen the plain head, they may give you a call to make sure you want to proceed with CTA. For example, if they find a large intracranial hemorrhage, you may elect not to move forward with CTA imaging. Then, continue working until the radiologist calls back with a report on the CTA. If there's an LVO, move on to part 3, send the patient to an expert center through Criticall using a code stroke EVT language when you call Criticall. This is a case we had just last week. This was a very young woman with no medical history who presented to a hospital with neglect and weakness on one side of her body. Unfortunately, it was felt she was malingering and there was a large delay, about 6 hours, to initial imaging. Once she was imaged, it was recognized that she actually had a large vessel occlusion. You can see that marked by the yellow arrows. Her M1 area is completely taken out. You also see on her MRI that she has a fairly significant volume stroke. She was eventually transferred to our hospital where she got EVT based on perfusion scanning that indicated she had decent collateral flow and would probably have good recovery with reperfusion. Here are some additional resources if you would like. Again, my name is Blair and it's been a pleasure chatting to you about identifying LVO strokes that might be amenable to EVT therapy.